welcome to another edition of the CURiE podcast. We are joined by another author, and I'm the editor-in-chief, Jessica Schuster, currently serving as faculty of the University of Wisconsin and at the Madison, Wisconsin Veteran Affairs Hospital. So welcome. Give us a brief introduction to yourself and kind of how you found the niche of radiation oncology.
Yeah, my name's Raj Singh. I work at Ohio State in Columbus, Ohio. I specialize in CNS and spine, as well as thoracic cancers, and then pediatric cancers. And we're fortunate to have 3 pediatric radiation oncologists. So I then subspecialize for Wilms tumors and neuroblastomas. Really got interested in radiation oncology actually through, I knew I always wanted to do oncology. That's kind of what got me interested in medicine initially. Initially was looking at pediatric neuro-oncology. I work in a DIPG lab in undergrad. But I was interested in radiation because I wanted to keep the option open personally of treating both adults and pediatrics. I wasn't quite sure which route I wanted to go at the onset. So it was nice to be able to keep kind of those opportunities open for myself. And then, some niche kind of treatments as well in CNS that are, non-oncologic too. That seems to be growing, I think, outside of CNS as well. But, and AVMs, trigeminal neuralgias, we have a pretty strong functional program at our institution too. So figured it'd just be exciting. And it's always kind of humbling to meet everyone from every walk of life and treat from head to toe. So keeps things fresh and interesting for sure.
Good. And after you get a good series of those functional treatment patients, you'll have to submit another article and we'll do another podcast.
Yeah, that sounds good.
And so we are enjoying your recent publication. So tell us a little bit about the background of the project. Where did the concept come from? And then kind of what were the steps that you guys took getting ready for the publication?
Yeah, definitely. So, we had done our group, and I work with Dr. Josh Palmer, who's my director of CNS Pediatrics. I'd worked with them in residency as well to do a study level meta-analysis in residency, starting to because pool outcomes for SBRT for pediatric and AYA patients has becoming more and more commonly utilized, I think, in challenging scenarios, be it either locally recurrent primary disease, and looking at the outcomes that we saw extrapolating from the adult setting, or certainly extrapolating again from its significant usage now in oligometastatic disease in adults. We also saw in some trials, like the Euro-Ewing trial, that there seemed to be benefits for patients in terms of survival when we not only treated the primary disease, but were aggressive in ablating metastatic sites of disease as well. And so our initial study level meta-analysis seemed to suggest that there's a dose response, particularly in sarcoma patients, going above a dose of anywhere from 35 to 40 gray in 5 fractions. And there were some small prospective trials that have been done as well. But we were interested, and what we're really trying to do as well is find subgroups of patients that might be candidates for an individual patient level meta-analysis. And we wanted to also see if these outcomes also tracked in community centers. And so the benefit of the registry we utilize, which is through the Radiosurgery Society, it's primarily actually a community-based registry center. There certainly are a few centers that are academic institutions, but the vast majority are community-based. So you want to see if some of the outcomes we were seeing tracked in the community as it had been in academic series as well, to see if those real-world outcomes were what we were seeing through this analysis. So that's kind of what led us to embark on the project.
That's fascinating. Is that, tell me a little bit about the registry setup and invitation to participate.
Yeah, so it initially was a CyberKnife registry. It used to be called the Record Registry, so it had CK in there, but now it's essentially any center that treats with SRS or SBRT, either community or academic based, is welcome to join. It has a standardized recording system. So what's nice about this is This way, all patients are logged in a similar fashion in terms of local control. If pain is documented up front from a palliative setting, you have their upfront pain score, and then at follow-ups, if that's been recorded, you can look at that as well. Survival, and you can then kind of organize the data based on the amount of follow-up as well, if you have a minimum or maximum amount of follow-up you're interested in, as well as histology, age, et cetera. And so now it's treatment agnostic, at least in terms of the platform. So it can be Linac-based, CyberKnife, any means by which. So they have over 25,000 patients now in the registry, and now there's enough robust follow-up for a fair amount of these patients as well. So it's become a pretty well-oiled registry machine in some ways, because some issues with, NTDB or SEER, certainly from a radiation oncologist perspective, is we don't have local control data. So this is kind of nice, where we can look at the outcomes that we're really interested in as radiation oncologists as well.
And from the registry standpoint, is there any barriers to entry other than being a volunteer to submit your data?
Yeah, so to be able to utilize the registry's data, there is a minimum requirement of contributing about 50 patients a year to the registry, which I think almost every center at this point, given SBRT is so pervasively used, and SRS. So there's no limitation with respect to the diagnosis or indication you're using it for. But that is a requirement of the registry, just to make sure that everyone's kind of being a fair player. That if you're going to use the registry's data, you're also participating, helping others. I believe initially to get set up, there is a nominal fee just to help because there's a fair amount of staff that are also involved once you put in the request to be able to actually pull the data, do the screening, and then actually have it in a nice Excel file. So what's nice is, though, by the time then you're ready to work on a project, most of that data has already been very nicely curated. So it's a way of it's a prospective registry. So it's really helpful in that sense. You don't have to go back to the onerous difficulty of doing a chart review and a specific IRB for each of these, because it's all built into the registry that's any SBRT or SRS project as well.
Oh, excellent. Well, let's get to the article at hand. Give us a little bit of a summary of your findings.
Yeah, sure. So this study, initially we wanted to look at really any pediatric or AYA histology. Unsurprisingly, as I discussed earlier, since it's primarily community-based, this tended to be mainly a adolescent and young adult, primarily based population, but still with similar histologies that we initially looked to when we classify these. So we did exclude, for example, younger patients with breast cancer, prostate cancer that might have just had bad genetics, such as BRCA1, et cetera. We really wanted to focus primarily on the histology question for this. So we identified 19 patients with 39 lesions that were treated with SBRT, with kind of a mix of different histologies, certainly a fair amount of sarcomas, primarily, as well as a decent amount of CNS primaries as well that were actually noted to have spinal metastatic disease, which gave a little bit of heterogeneity, I think, to this population compared to some other ones where we haven't really seen these outcomes reported. And then I think led to some interesting findings in terms of outcomes that we saw. The median dose per fraction, and we utilized biologic effective dose. It certainly has limitations, but it's the easiest way, at least, to compare between different dose fractionation schedules. And that landed at about 61.5 gray with an alpha beta of 10. And again, the ages definitely were on the higher end. The median age was 34, but with a range of 16 to 39. So anyone above 39, we did exclude from the study. What we found was, and then the median dose and fractionation was 35 gray and 5 fractions, which correlates with that 60 gray roughly BED10. And the outcomes in terms of survival were what to be expected, I think, in either of these scenarios. I mean, the majority of these cases were SBRT for metastatic disease. 34 of the lesions, 5 were used in the setting of reirradiation for local recurrences. All of those were sarcoma cases. None were SRS or in the setting of gliomas or CNS primaries. And what we found was with respect to survival, because of all the heterogeneity that were among the different histologies and disease courses, we couldn't really find a signal. But that wasn't really the primary outcome. We really wanted to more so look at it. Was there anything that correlated with control, be it either histology or dose and fractionation? And what we did find first was that kind of what we've seen in the adult settings as well. When we use SBRT and ablative doses of radiation, sarcomas, which we traditionally consider to be radioresistant, actually have very, very good local control when treating with SBRT, because the majority of these cases were cases with lung metastases, where we're able to really deliver ablative doses similar to what we do for early stage non-small cell lung cancer. So really, really excellent local control, exceeding 90% for those cases. And then when we looked at the CNS primaries, that's where we saw pretty dismal outcomes, sadly, as one might expect once you develop true metastatic disease. Control really was quite poor, as well as their survival outcomes. But certainly the sarcoma patients had quite durable control, which was good to see, and tracks with the prospective data we have in the pediatric SBRT setting. The other finding with respect to this was we did find that patients that were treated with BEDs of greater than 60 gray did have a superior local control as compared to patients that were treated to less than 60 gray. And this did hold up on a multivariate analysis when we try to control for some of histologies, again, certainly with the limitations of a small patient cohort, though. So our recommendations typically when trying to plan these is to try to exceed a dose of 35 gray and in 5 fractions. If you're in 5 fractions, you're doing the BED calculation. Some other studies suggest in some of the prospective trials 40 gray in 5 fractions, I think, per the Cleveland Clinic data too. And I think particularly for the still more traditionally radioresistant histologies like osteosarcomas, that certainly I think is very reasonable too if it's achievable based on OARs. But those were some of the major findings that we saw that seems quite in line with the literature that we saw in academic centers.
I think it's nice to have kind of the verification, the quote unquote phase 4, what is
Sure.
happening in real world. Also, I mean, just even a look at what is it that people do feel comfortable doing kind of outside of a clinical trial. Or, and there's always challenges of doing what's right for that patient in front of you, balanced with where are we at in the solid phase, 3 available data. So I thought that was interesting that there was a clear kind of pattern in the study for sarcoma and CNS. And so, we're not probably changing a ton, but based on kind of the findings, but what in a, kind of probably in your clinic practice, but it sounds like the review itself has potentially influenced some of your thoughts on dosimetric planning. So kind of give us a little bit of a summary of how this review and paper has kind of influenced you for your practice.
Yeah, certainly. So, I mean, I think now we're becoming more and more vocal, I think, at Tumor Board in these oligometastatic cases in pediatric settings, where historically, I think similar to adults with sarcoma, lobectomy, wedge resections, these certainly can be done, but we know that systemic therapy is paramount for these patients' outcomes, and it can lead to significant delays and breaks in systemic therapy to get a resection. So I think particularly in sarcoma patients with disease, we have more and more data, I think, that's building to be able to, support a non-operative approach with very, very good outcomes with minimal interruptions and what patients need for their outcomes. The other component to this is kind of, I guess, next steps as well with respect to research, because based on the study level meta-analysis we did, we similarly, when we excluded just neuroblastoma patients that are a bit more radius sensitive, we did also see a trend towards improved control with higher dose per fraction. So there are we're trying to conduct now an individual level, patient level meta-analysis using this data, as well as data that's been published from St. Jude and other centers, to really, I think, getting to more specifics, because I think particularly too, what we want to start characterizing for more adoption of this is, toxicity is a concern in pediatrics, certainly too, and particularly for reirradiation. So what our goal now is to start to capture more of the dosimetric data, see if there were toxicities and correlate that in pediatrics. Just like the Pentec effort, I think we're seeing. I think it'd be great to see that for pediatric SABR, just like we have for adult SABR too. So I think those will be the big next steps based on the signals we're seeing in multiple studies, because it's just so difficult to do a large prospective trial, just given the rarity of these situations. So I think the next best thing is taking advantage of people that have been, I think, visionary and applying these same principles to pediatric settings as we've done in adults, and then extrapolating based on their experiences. So.
No, that is great. I mean, there have to be alternatives when the diseases become more and more rare to your 1,000 patients. Not like breast and prostate world.
Right. Yeah.
Be
Yeah.
creative of trying to figure out the right pathway. Of course, in our pediatric patients, they've done such a nice, robust job of kind of being inclusionary in their clinical trials. But some of our AYA patients, which a lot of
Yeah.
times do have those sarcomas, the folks that you're looking at, sometimes they fall a little between the cracks. I think there's
Yeah.
more of our pediatric studies do seem to be bumping up those age kind of
Yeah.
limits, but still not always falling into that clinical trial availability too.
Right.
How about a last kind of parting word for those of us who don't see that many peds? And certainly, me personally, I've never SBRT'd a ped, although we did present that today at our chart rounds.
Wow.
Um, what kind of tips would you have if we were meeting a young adult or a pediatric patient kind of out in the community?
Yeah, I mean, I think in terms of contouring dosimetry, the same principles apply to a pediatric case as an adult case. We always, say we like to make sure the low dose pass is even a bit lower, but I think that's what we ideally should be doing in adult cases as well. But I think just as any other case, just patient selection, particularly for lung, the same principles apply: peripheral versus central, consideration of more hypofractionated courses, if it is more central, but just like we do in early stage non-small cell, still trying to achieve that ablative dose in more creative ways. So I think just uh, patient selection as always. But so I think, I mean, I've only done a few, but my first year, of course, because it's still not the most common thing to do, even for a pediatric radiation oncologist. But I'd say my approach is generally quite similar. But of course, I always look at the dosimetry a little bit more closely in the plan, I think. But I can't say necessarily there's one specific thing maybe I do any differently. I think the reirradiation cases though, for let's say like a Ewing's, just thinking about OARs that we don't necessarily always consider when we're doing some of these cases, so really sacral plexus and other considerations, or really considering the risk of fracture and considering your hot spots as well, are things to consider in those cases, though, where, in a standard SBRT case, inhomogeneity is great, but sometimes you want to think about those considerations too in areas that might have already been definitively dosed.
Mm-hmm. And I think it's always great to know the specialist. So thanks for being my friend.
Oh, sure. Yeah.
And the phone a friend. And then of course, referral, I think, to a specialty
Yeah.
site is probably where most of us would lean,
Yeah, sure.
give
Sure.
patients a little push. But clearly, based on this data analysis, there are times where, and we've all met patients like that. They can't travel. They
Yeah.
are too sick, and, you're kind of stuck and rely on small series, or that communication between specialists to kind of help guide us with that individual case. So thank you so much for taking the time to chat with us today, and continuing to help move the field forward, particularly with the AYA population. It's kind of it was for a while a forgotten niche, and now it's almost,
Yeah,
I could foresee us having AYA specialty oncologist, uh,
yeah,
kind of as a more routine in people's practices. So, and
definitely.
CNS and sarcoma for sure bridge that gap between peds and adults many times.
Yeah, definitely. Definitely. Yeah, I've treated many already AYA gliomas where it's very, I think, different. Like the way you approach, I think, the patient, B, the case. I mean, all the considerations, I think, too. So I definitely agree. It's something that I think many of us see more and more in practice. So I think it's good to see that there's more data coming in that population. Certainly, I agree.
Excellent. Any final thoughts?
No, none I can think of. I will say, even us as specialists, we always phone friends too. And luckily, I mean, if there's ever a pediatric or AYA case, I've actually found that, the pediatric and AYA community is one of the most responsive. Like I'll send an email to someone, I think in 5 minutes, I have the most detailed essay or thesis on the specific case I've ever seen. And then, you'll get information on protocols and development that you wouldn't have even known about too. So I had a recent pleural pulmonary blastoma of the lung, and I never would have even known. It's like, oh yeah, there's this protocol in development. This is what I would recommend. I mean, very detailed, great help too. So certainly, I think hopefully I speak for others though that we're always happy to respond and provide advice whenever, because I definitely know I've sought more than enough in my short time as an attending so far too. So
Wonderful. Well, thank you again. And this concludes our Curious Podcast edition. We're very thankful to our authors, and we look forward to future publications, and look forward to reviewing the next set of articles that come through for publication. So far, we've had lots of diversity of articles, and I look forward to continuing to share people's work. So